And one. We're live.
Good evening, everyone, and welcome to this edition of the SESI Journal Club. And we've had two successful and productive meetings earlier. And for this meeting, we have none other than Dr. Ashish Bhabulkar himself moderating this session. And the theme chosen is superior capsular reconstruction. It is a controversial subject, as everyone would agree. And we've got some excellent papers curated by him, Dr. Ashish himself. I invite our president to give his comments, and then we'll go straight to the topic.
Thank you very much, Karthik. Again, I think, as you said, a very important topic, and that's one of the surgeries which are in vogue at the moment. I think we'll look at the reviews and then decide whether we should go ahead and do the surgeries or not. I think we'll start off with Ashish. Ashish has been doing quite a few of these. I've seen him do it. I think we'll get his perspective today.
So, thank you, Nandan and Karthik. I'm very privileged to be in part of this meeting. And then we have Dinesh, Prashanth, and Ajikya who will give their analysis of the reports. I think we have handpicked some very good articles, each of them of a different flavor. So I would like to reserve my personal opinion. I don't want to distort the view of the speakers. They will have analyzed themselves. I will contribute to this as a moderator at the end of each session. And at the end of that, we should have a nice collective discussion, a good cross-exchange between all of us so that we can come to a sensible conclusion, because it is not the cut and dried yet. So we should know when to do, what to do, and what should we expect. So what is the duration that we have, Karthik?
Sir, each presentation runs for about 10 to 12 minutes, and then we have a discussion for 5-6 minutes. And then it's up to us. Usually we wrap up by around in 1 hour, but we can extend if things are.
No, that gives us at least 15-20 minutes for a healthy discussion. So allow me to reserve my comments. I'm going to listen very intently to these three speakers, and then we'll allow them to influence our decision. And then I'll give you my opinion at the end of it, and Radha and other team members can also contribute. So let's start with the first speaker.
Okay, Ajikya, you're on.
Yes, sir. I'm sharing my screen. Is my screen visible?
Yes.
Yes. Yeah. Go ahead.
Okay. So, good evening, all senior faculties and the presenter for today's journal club. At the outset, I would like to express my gratitude to Dr. Ashish Bhabulkar sir, SESI President Dr. Deepthi Nandan sir, and Secretary Dr. Karthik sir for giving me the opportunity to present at the SESI Journal Club. With the theme of SCR for today's journal club, I will start my presentation. The title of a published article is Arthroscopic Superior Capsular Reconstruction for Irreparable Rotator Cuff Tears, Comparison of Clinical Outcomes with and Without Subscapularis Tear. This article was published in AJSM, that is the American Journal of Sports Medicine, which is the parent journal of American Orthopaedic Society of Sports Medicine. It has got an impact factor of 5.4, and it is ranked number 9 among 136 orthopedic publications. It is indexed in PubMed, Opus, Web Science, Embase, and Directory of Open Access Journals. Now we'll go regarding the articles. So this article was published by Professor Tiruhasa Mihata in the year 2020. He belongs to Osaka Medical College in Japan. Professor Mihata is well known for his pioneer work in the technique of SCR, which shows a significant advancement in management of irreparable rotator cuff tears. Numerous publications are in his names, and number of citations are particularly cited for their technique of SCR. So this particular article was cited almost 47 times, and it has got a level 3 evidence. So I will start with the introduction. So superior capsular reconstruction procedure was developed for management of irreparable posterior superior rotator cuff tears. Biomechanical studies demonstrated that superior capsular reconstruction improves superior glenohumeral stability and restores force couple of glenohumeral joint. Irreparable subscapularis tendon tear combined with irreparable posterior superior rotator cuff tear decreases glenohumeral stability and reduces the force couple of glenohumeral joint, which leads to poor functional outcome. So the rationale for this study is, though this study not only highlights the results of SCR, but also provides insights regarding importance of integrity of subscapularis tendon. There is minimal evidence in literature addressing the influence of subscapularis on SCR. Aims and objectives and hypotheses of this particular article. The objective is to assess the effects of reparability of concomitant subscapularis tendon tears on the clinical outcome of SCR for irreparable posterior superior rotator cuff tears, with the hypothesis that the clinical outcomes after SCR would be worse in patients with irreparable subscapularis tendon tears. The study characteristics. So this is a retrospective cohort study. It is a single center, single surgeon study, and the study duration was from 2007 to 2015. So total final patients selected for the study are 193, and these 193 patients are divided into 3 groups based on the intactness of the subscap and the reparability of the subscapularis tear. So the number of patients with intact subscapularis was 160. The reparable subscapularis group has got a number of 26, and irreparable subscapularis tear has got a number of 7. So according to the PICO method of classification, I will present this methodology. So the patient in this particular paper are the irreparable rotator cuff tears. The inclusion criteria is the irreparable rotator cuff tears with or without subscapularis tear and failed conservative treatment for at least 6 weeks and the follow-up duration of at least 2 years. Exclusion criteria is the cases where the humeral head is severely deformed, that is the Hamada grade 5. These were not included. Controls were not included in this study, and the outcome was assessed with the help of scores like AACS and JOA, that is Japanese Orthopaedic Association score. Pain was calculated with the help of visual analog scale, active range of motion, muscle strength, and the acromihumeral distance. So the surgery was performed by Professor Tirwasa Miyata himself in all the cases. Whenever there is a severe dislocation of a biceps, either the biceps tenotomy or tenodesis was performed. Acromioplasty was done in all the cases. No intervention was performed in cases where the subscapularis is irreparable. The post-operative protocol is the 4 weeks immobilization in the abduction sling was given. After 5 weeks, active and passive range of motion exercises are started, and after 8 weeks, the muscle strengthening exercises are started. Clinical and radiological assessment was done at pre-op and final follow-up at 2 years, mainly with the MRI for assessment of a graft integrity and reparability of subscapularis tear, and the clinical test for assessment of subscapularis muscle, which is mainly the belly press test and the internal rotation lag sign. Muscle strength was calculated with the help of manual muscle testing in the scale of 0 to 5. And the scores, as I've explained, are the American Elbow Society scores and the Japanese Orthopaedic Association scores. Statistical analysis was done for various quantitative and qualitative parameters. So the quantitative parameters, mainly the age, tear size, graft size, the scores, the active range of motion, and the muscle strength was calculated with the help of ANOVA test, that is the parametric test. Then the quantitative parameters were compared preoperatively and postoperatively with the help of t-test or Mann-Whitney test. And the qualitative parameters like the Hamada's grade, Gautelier grade, biceps pathology, and the complication rate were compared with the help of chi-square test. Then comes the power of analysis. So the appropriate sample size was calculated with the help of G power to the 3 statistical analysis software. The total sample size of 193 patients provided 80% power to detect the significant differences in post-operative scores and active elevation among the 3 groups. So this is the main heart of this article, that is the main results. So I have summarized all the results in this particular one slide, where you can see the topmost row is the subscapularis status, where you can see the 3 columns are prepared on the basis of the intactness of subscapularis muscle, the reparable subscapularis tear, and the irreparable subscapularis tear. And the rows are divided according to the parameters. So we'll go one by one. So as per the age, the youngest age group was the reparable subscap tear compared to the other two groups. And the Gautier grade of fatty infiltration, it was highest in irreparable subscapularis group, amounts to grade 4. Tear size, anteroposterior dimension, it was larger in both reparable subscapularis tear and irreparable subscapularis tear. The biceps pathology and the rate of percentage was higher in cases of irreparable subscap group. So out of 7, the 2 patients were either done with the tenotomy or tenodesis. Visual analog score has decreased significantly in all the 3 groups. The ASES and the JOA scores improved significantly in all 3 groups. But the mean score values were significantly low in the 3rd group, that is the irreparable subscapularis group, as compared to the 1st group. The range of motion, mainly the active elevation, active external rotation, active internal rotation, improved significantly in first 2 groups, that is the intact subscap group and the reparable subscapularis group. It did not improve in the 3rd group, which is the irreparable subscapularis group, and the active elevation, active external rotation, and active internal rotation was less compared to the other 2 groups. Muscle strength has also the same results. It improved significantly in the group 1, that is the intact subscap group, and the group 2, that is the reparable subscap group, and it did not improve in case of the irreparable subscap group. So this is the particular summary of the results. Then comes the particular parameters testing for effects of subscapularis reparability. So the acromiofemoral distance was increased post-operatively in both reparable subscapularis group as well as irreparable subscapularis group. But the increment in the acromiofemoral interval was pretty much less as compared to the less in the irreparable group as compared to the reparable group. Belly press test was negative in all the cases post-operatively in reparable subscapularis group, and it was positive in 29% cases in the irreparable group. Internal rotation lag sign was negative in both, that is reparable and irreparable group. Then we come to the complications. Complications also I have summarized in a tabular form, where a subscapularis re-tear was not seen in any repaired subscap group. Superior capsular reconstruction graft tear was seen in total 9 cases, 3 in each group. So it amounts to 2% in intact subscap, 12% in reparable subscap group, and 43% in the irreparable subscap group. Out of 9 patients, 1 underwent RSR, that is reverse shoulder replacement. 1 was done with the revision superior capsular reconstruction, and 7 cases were not operated because they didn't have any pain. The infection was also measured complication. So it was maximum in the irreparable subscapularis group, which is 57%. The main organism is Propionibacterium acne. In these cases, arthroscopic debridement was the only procedure performed. No graft was removed in any of the infection debridement cases. Severe stiffness was noted in 2 out of 160 cases in the intact subscap group and 1 in 26 out of the reparable subscap group. Discomfort in gluteus maximus muscle side. This is the very typically seen in 2 patients, that is 1 year after surgery, and for this they underwent the repair of the gluteus maximus, but no patient had pain at the graft site in the final follow-up. So I'm mentioning the limitations, but I would like to mention that these are not exactly the limitations considering the rarity of this particular pathology. So the small sample size in irreparable group, it is bound to happen because it's a very rare situation where the subscap is irreparable. The follow-up duration of is short is mentioned in the literature in this particular article, that is mean of follow-up of 3 years and 7 months. But this is the longest follow-up till for this particular pathology as I came across through all the literature. The larger tear size is bound to be there because in cases of reparable and irreparable subscapularis group, because as there is a tear of subscapularis, the tear size of the posterior superior cuff will also increase. The biceps treatment rate is also increased in the cases and is different in different groups. So it is bound to happen that the cases where there is a subscap muscle is torn, the biceps pathology will also be there and it is higher. So I am mentioning here few cases. This is a 56-year-old gentleman where a revision case of arthroscopy rotator cuff repair was done with the help of SCR. As you can see in the pre-op X-ray, there is proximal migration of a humeral head, and in the post-op day 1 X-ray on the right side, you can very well see that the humeral head is centered. This shows the reverse trampoline effect provided by the superior capsular reconstruction graft. This is another case where the 56-year-old gentleman has a chronic greater tuberosity non-union of almost 18 months. In the pre-operatively, you can see that there is decrease in the active elevation as well as the decrease in active abduction. This is a case of irreparable rotator cuff, posterior superior rotator cuff tear. So you can see at the final follow-up of 7 years, the patient is able to elevate the right arm completely, almost normal, as well as the abduction also improved significantly at final follow-up of 7 years. Now I would like to quote few literature. So this is a study published in 2021 by Takayama. So this study mentions that subscapularis is a very important factor for the results of SCR in pseudoparalysis patients. In this study, they have divided the groups according to the Hamada's grade and the presence or absence of shoulder pseudoparalysis. And according to this study, the result is that the subscapularis is important for SCR results in pseudoparalysis patients. Then this is a very interesting study by the Hartian group from USA. So this is particularly important for the literature review, as you should know the information about the spin. So spin in the literature refers to the use of flowery language to twist or manipulate the presentation of results, making them appear more useful or favorable than they truly are. So as you can see, I've highlighted here that the studies have shown that physicians often make clinical decisions based on primarily on the abstracts, and the abstract is a common place for bias and spin to occur. So in this particular paper, total 17 systematic reviews were analyzed, and the spin were divided into 15 types, out of which the type 9 and the type 5 are the most common spin which we can see in the literature. So which mainly includes that the beneficial effect of the experimental treatment is reported despite there is a reporting bias. Then the next study by the Professor Peter Millett, where the minimum follow-up of 2 years was done for the irreparable subscapularis, irreparable rotator cuff tears, and compared with the reverse shoulder replacement. The reverse shoulder replacement has got 33 patients, and the average age was 63, and the SCR patients were 22 with the mean age of 56. I think one of our presenters is going to speak on this particular paper. So I will not mention more about this paper. So I will mention shortly that the young patients treated with either SCR or reverse total shoulder arthroplasty showed significant improvements in the short-term follow-up. From here, I will come to the conclusion. So whether it's a intact subscapularis and the reparable subscapularis group, both provided the beneficial effect with superior capsular reconstruction. The group 3, that is the irreparable subscap group, is at the increased risk of graft tear and post-op infection after superior capsular reconstruction. The risk of graft tear is increased because as you can see from the results, the acromihumeral interval was not significantly improved post operatively in the cases of irreparable subscapularis group. The group 1 and 2, that is the reparable subscap group and the intact subscap, these are the best indications for SCR because they are able to restore the superior glenohumeral stability as well as restores the force couple for the glenohumeral joint. So the group 3 remains unanswered. So we still are in a particular puzzle whether to operate in cases of irreparable subscapularis tear group or not. And also, I will like to boost the discussion that what is the cutoff age for SCR. So I would like to conclude my presentation. Thank you.
You can unshare your screen, Ajikya.
Yes.
Excellent presentation. You summed up the paper very well, and it is a wonderful paper. So let's have the view of the moderator and the panelists and others who have joined.
So meanwhile, if there are any questions, feel free to write on the chat group so that we can take them simultaneously in a systematic manner. So Ajinkya, what is the importance that Mihata is trying to convey to the rest of us through this paper?
So Professor Mihata is mainly focused on the reparability of the subscapularis group and the intact subscap group. So he mainly showed the results that the groups, the intact subscap and the reparable subscap, both have significant results. But in cases of irreparable group, because of the small sample size, which is there is the concomitant irreparable subscap as well as the irreparable posterior superior rotator cuff tear, it is a very rare. So the sample size is naturally small, but still he has shown better results in the irreparable subscap group, where the patients were post-operatively has good pain relief. The functional outcome, though it was not significant, but the pain relief was the most important feature in cases of irreparable subscap group.
Correct. So this is very important to understand that the SCR is not magic. And the fact that one is doing SCR, it is unlike Bankart or rotator cuff where there's a structural deficit, we are repairing it and restoring the patient's function to normal. So we must understand that SCR facilitates the patient's function to come back to normal. So this is open to the other two panelists also, Prashanth and Dinesh as well, that we should understand what are the correct patient's indications that will deserve an SCR. So if you can systematically analyze and understand from this paper and what you all have read, so what are the patients that will certainly benefit from an SCR, given the whole plethora of literature available to us, and there's a lot of mixed masala literature available. Dinesh, you want to like to comment?
Yes, sir. As Ajikya is demonstrating all these things, as I think what Mihata is exactly to tell is to restore the transverse force couple. Once the subscap is addressed, or if it is intact, then the stress on the superiorly placed graft is much lesser. It reduces the re-tear rate also, preventing the anterosuperior escape.
Correct. So excellent. So, and then what are the other factors you would consider in the ideal patient? So if you have to define that this is the patient, I think at the end of the day, today, we will define that this is the patient that will benefit with SCR. Because not all patients are going to improve.
Those are less than 65 years of age with pseudo paralysis, with good external rotation, or at least negative horn blower, so that at least teres is intact, so that we can stitch back the remnant to the posterior side-to-side suturing. And
nice. So, except you, I think you phrased it very nicely that you want a young patient who has a massive isolated supra tear. The transverse force couple should be intact, or if it is not intact, then it should be reparable, the subscap.
Yes.
And you don't want Hamada 5 there. So you don't want cartilage changes. So 10 years back, if this webinar was conducted, we would have said that proximal migration or a pseudoparalysis was a contraindication. But from Mihata's articles and our experience, we've realized that pseudoparalysis can be reversed. Both Basam, Mihata, and ourselves have noticed that it is not a strict, hard contraindication to doing an SCR, but provided there are no cartilage changes, because SCR is not magic. So you can't take randomly every cuff tear patient, which is irreparable, and go ahead and do an SCR on them, right?
Yes.
So that is appropriate. Any other questions, queries from the other panelists?
May I ask a
Yes.
question? Yeah, Dr.
Go on,
Ajikya,
Sujit.
there is a statement here that the internal rotation lag sign has become negative in both the groups, in the reparable as well as irreparable subscap tears. So why would you
Yes.
suppose that would have happened?
So the internal rotation lag sign would have been particularly negative in post-operative patients because it's not the isolated subscapularis muscle which helps in the internal rotation. This particular thing has happened because the other muscles leading for the internal rotation must have helped to maintain the lag sign post-operatively. And because of restoration of the superior particularly the integrity of the rotator cuff, this could have helped as opposed to the belly press test. So belly press test significantly involves the subscapularis muscles. Isolated involvement of the subscapularis can be done with the help of belly press test. So this was in particular explanation I would like to give.
So I think,
Okay.
Sujit, the group 3, the
Complete
sign was not
irreparable.
reversed. Was not in the irreparable group. It was not reversed. It was reversed in group 2, if I'm not mistaken, because they had a group 2 had a subscap tear which was reparable, and post repair it became negative. But a significant number of those who had irreparable tears, it still remained positive in that group, and we can understand that. Good point. Shall we move to the next paper, because there's a lot of discussion that is pending, and we'll combine all that with Ajinkya and Dinesh's paper as well.
Good evening, sir. Able to see my screens?
Yes.
Yes, sir. First of all, thanks SESI team and Karthik sir for this opportunity. Today I'm going to present about the systematic review published in JSAS in 2020. This is a superior capsular reconstruction for irreparable rotator cuff tears. This is a systematic review of biomechanical and clinical outcomes by graft type, published by Justin et al. So the introduction, we all know the massive rotator cuff tears are often challenging to treat because of the chronicity, which becomes irreducible because we won't get the tensionless repair is the ultimate goal of the surgery. And because of the chronicity, there is significant atrophy along with fat infiltration, which precludes the repair because the re-tear rates are very high. So as I mentioned earlier, the coronal plane and the transverse plane, the balance force couple is lost, particularly in chronic scenarios, leading to the unopposed pull of a deltoid muscle, which ends up in the superior translation of humeral head, hinging against the acromion. That causes subacromial impingement and significant pain in such scenarios. Because of the added kinematics, the function is lost and they tend up in stiffness. They have compromised quality of life. So in such scenarios, the various treatment options, we might end up in partial repair sometimes, but the risk of failure should be kept in mind, which is about 52%. The role of tendon transfers and particularly reverse shoulder arthroplasty, where we can reserve them for more than 70 years because of the higher complication rates in patients less than 65 years, with a failure rate of about 25% at the end of 2 years follow-up. So then came the role of superior capsular reconstruction by Professor Mehta. He first demonstrated this technique using facial ETA. According to him, the superior capsular reconstruction restores the balance force couple, thereby resisting the superior translation of humeral head, which can be very well demonstrated using the acromio-humeral interval, and thereby decreases the subacromial contact pressure and increases the joint compression force. Because of the early promising results with excellent pain relief and improved function, there were almost 18,000 surgeries at the end of 2018 worldwide. So as day progressed, because the donor side morbidity from the thigh part, the role of dermal allografts were proposed as an alternative to the routine facial autograft. So coming to the study part, this aim is to review the biomechanical and clinical outcomes in shoulders with irreparable cuff tears treated with SCR and various techniques with special consideration taken to present the results based on the graft types. This is a level 4 evidence with this is a systematic review. Methodology. This review was conducted following PRISMA guidelines using PubMed, Embase, and Cochrane databases. Out of 634 records, after screening and eligibility, they included 17 studies. If they reported biomechanical, radiographic, or clinical outcome data after patients who undergo SCR in irreparable scenarios. From these 17 studies, 8 were cadaveric biomechanical, 5 includes autograft clinical outcome studies, and 4 allograft clinical outcome studies. So there were 8 biomechanical studies. First one is Rami et al. In OJSM 2018, where he compared tensor facial autograft versus long head of biceps autograft, and he showed that long head biceps SCR is a feasible procedure and is much stronger even than facial autograft. That was his conclusion. And the second biomechanical cadaveric study, where Mehta et al. They compared facial allograft versus human dermal allograft. He concluded that facial allograft restores the superior translation completely, but the human dermal allograft fails to restore completely. It restores partially because it tends to elongate subsequently. The same Mehta paper, based on another biomechanical cadaveric study, where he evaluated the thickness and tension of the facial graft, and he concluded that at least the thickness of 8 millimeters and with shoulder in 50 to 40 degrees of abduction restores the shoulder stability. Another cadaveric study by Mehta, where he added that acromioplasty should be done in all the cases so that it decreases the contact area subacromially, so that the risk of re-tear and further abrasion in the long run is avoided. One more paper from him, where he continued, where he demonstrated the role of capsular continuity. As I mentioned, he side-to-side suturing between the graft to the residual infraspinatus tendon improves superior stability. And one more paper from him, where he showed that patch grafting comparison, when it is stitched back to the remnant tendon, it doesn't restore the superior translation. Whereas when we do routinely to the glenoid end, then it restores the superior stability completely. This paper by Pogozelski, where he compared 3 different techniques based on the glenoid fixation, and one more by Supriya Singh, where he compared the spacer versus SCR. Initially, they told during abduction the spacer worked better, but at the end, there is no significant difference between these 2 procedures. So out of 8 studies, the 6 out of 8 studies, they assessed the superior translation, and 2 of them, they showed it was restored the superior stability. Particularly the graft thickness and the side-to-side suturing posteriorly is essential for achieving that. And 5 out of 8 studies, they assessed subacromial contact pressure, and 5 out of 5, they told, they concluded that the contact pressure was very much decreased, particularly after facial allograft. And 3 of the 8 studies, they assessed glenohumeral compression force, and much of them did not contribute to the increased compression force. So coming to the clinical outcome studies, totally 5 studies, and 3 out of 5 were from the same sample by Mehta. So 3 non-duplicate studies are available for evaluation. This is the clinical outcomes with facial autograft. So in these 2 studies, they evaluated the functional ASCS scores pre-op and post-op, which increased subsequently from 19.3 to 56. And in these 2 articles, they assessed the acromiohumeral distance, which is the indicator for superior stability, which increased from 0.7 to 1.1. And in these 3 studies, they showed elevation, forward elevation is particularly improved from 13 to 69, and the external rotation improved from 2 to 22.4 degrees. So these three articles, they assess the graft treated rate, which was about 5 to 29%, and they commented the most common pattern of graft failure in these scenarios is particularly at the medial row. Though the re-tear happens, the pain, VAS score, and A score improved regardless of the tear. And preoperatively, when they were assessed, the acromial distance was significantly lower in the graft tear group than in the intact graft group. So coming to the allograft clinical outcome studies, they included 4 studies and 3 were available for evaluation. In this, the Burkett paper was included in the denied case volume. So these 3 studies were available for evaluation. In these 3 studies, the mean acromial interval increased from 0.1 to 3.1. And the ASA scores increased from 29.1 to 43. And the visual analog score pain scale has decreased from 5.9 to 2.5. In these 2 studies, the mean forward elevation has increased from 20 to 39. These are the outcome studies. First one was biomechanical cadaveric, 8 studies, and next one was 9, of which 5 was autograft, 4 was allograft. Coming to discussion part, according to Mieta, the capsule, once it is reconstructed, it acts as a resistant to the superior translation, which is very well supported by 2 out of 6 biomechanical studies and 5 out of 9 clinical studies, where it showed that the acromial subsequently increased after SCR. And of 8 biomechanical studies, the 5 studies has very well documented there is decrease in the subacromial contact pressure after SCR. So this is just about anatomy, which is a thick sheet of collagen for about 4 to 9 mm. It extends from medial glenoid to the humerus laterally. Thereby, it acts in hammock, overlaying the joint and prevent the head from making contact with the deep surface of the acromion, just like a spacer. Coming to the clinical outcomes of SCR in terms of pain and function, out of the 9 clinical studies, both autograft and allograft, 5 out of 9, they showed very good improvement in ASA scores and decreased visual analog score after SCR in irreparable cuff tear scenarios. And according to Mieta, those who played sports before their injury, they returned to sports 100%. Some of the controversies in SCR, the first one, though he started using initially fasciolata allograft, later he started autograft from the thigh in his early studies. As I mentioned earlier, it was evolving. Then came the role of dermal allografts because of donor site morbidity. In this journal, which I demonstrated earlier, both human dermal allografts and fasciolata allografts or autografts, they are able to restore the subacromial contact pressure and glenohumeral joint compression force. But the superior translation was mainly completely restored by the fasciolata graft and only partially with human dermal allograft. Where he concluded that because the allografts, the human dermal allografts, they significantly elongated by 15%, whereas from a fasciolata allograft, they remain unchanged. That's the reason for subsequent elongation and partial restoration of the superior migration. So this paper about the graft thickness, as mentioned earlier, it's about 4.4 to 9 millimeter thickness. And in this paper, the diameter and the thickness of the fasciolata was evaluated, where they showed 4 mm and 8 mm thick. Both of them, they reduce the contact pressure, but only the thicker graft reduce the superior translation. According to Hirahara et al., where it showed at least a graft of 3 mm thickness should be adequate. It should be a minimum cutoff so that the functional scores improves and visual scores, pain score comes down. Other technical considerations, as I mentioned in the earlier biomechanical studies, during the anchoring the lateral aspect, the shoulder should be kept in 15 to 40 degrees so that it restores the superior stability. And using the fasciolata allograft, Mehta recommended posterior side-to-side suturing alone, and he advised to avoid better anterior suturing subscap as it compromises the post-op range of motion. But there is no difference when we use human dermal allografts. Even if we suture both anterior and posterior, doesn't matter. And as earlier suggested, acromioplasty should be done in all cases as it reduces the re-tear by avoiding the abrasion. Coming to the limitations in the biomechanical study, that being a cadaveric study, there are no active muscle being involved. It's a static loading, and it always represents the time zero because At the time of repair, it's okay, but in the long run, how it's healing, it's not been assessed. And of all the 8 studies, 5 were by the same author who designed that SCR technique. Despite all these limitations, whatever is work in the biomechanical studies, they lead to the successful execution of SCR at present. In clinical studies, few limitations where most of them are technical articles retrospective only by few groups. And similarly, 3 out of 9 were by the same Professor Mehta et al. And there were no lack of comparative studies between various treatment options. And without comparison outcomes, it's very difficult to determine the best surgical option. And the main thing which I want to highlight is we have to differentiate between pseudoparalytic patients with true dysfunction versus pseudoparalytic patients with preserved function. So, and current techniques should be focused on restoration of overhead motion, which is still lagging. So, conclusion, it is an superior capsular reconstruction is a viable surgical option for irreparable cuff tears, particularly for patients who are less than 65 years. And biomechanical studies stated that the humanoid stabilizing effect of SCR leads to improved clinical outcomes, as we could see the data. And future research, we should focus on absolute indications, limitations, and optimal technique. Thank you.
Excellent job,
Wonderful.
Dinesh. I think
Thank you.
that's a good summary of published literature. We must understand that this is a meta-analysis or a review. It's not a prospective journey, or it's not a scientific article. But at the end of it, based on the review article, we get to understand so many variations in the graphs and the techniques. I think the important paper here was the Mihata paper from 2012, where he compared the acellular dermal graph versus the IT band and comparing their ability to reduce the proximal migration, and the IT band was far superior. You must understand that that article was published with Thaikyu Lee. Thaikyu Lee is a biochemist based in USA who has his own lab. So Mihata spent almost 3 months with him and doing various combinations and finding out the inherent strength. Of course, these are biomechanical studies based on cadavers. We can't extrapolate them completely. I believe Radhakant Pandey from Leicester has raised his hands. So can we have a question from Radha? Radha, you are muted. You need to unmute.
Okay, can you hear me?
Yes.
Yeah. So there was when those comparisons were made, nowadays the allograft, you double them, so you made them double thickness. And in 2024, this year, there are a couple of very good papers which have come out. One is from Martin Snow, in which they have doubled the graft, and that has improved their function significantly. And a lot of the previous studies have got a single layer allograft. And there's always this debate about whether the allograft should be fixed to the glenoid or the residual muscle. We have tried both, and we still feel stitching to the muscle gives equal amount of joy to us. The other thing in 2004, in Back et al., who also published in arthroscopy, which is where Mehta has published most of his articles. The re-tear rate is 62%, but all the people who had a re-tear still had reasonable function. They had better function than pre-op, but the muscle power does not improve. So their range of movement may increase, their pain may get better, but their muscle power is definitely not better, and that is absolutely important. And one of the things which a lot of people are doing, a lot of meta-analysis is available about biceps tendon SCR. And I think that is slowly catching up too. And it's an attractive proposition, which I don't know if this will be discussed somewhere today, but that is that is one of the things which is slowly catching on. And I'm sure it's happening in India a lot. Thank you.
Yes, yes. Rather, I think very pertinent points. I have marked down already various different graphs and the repair of the patch versus the SCR. We are definitely going to cover that. We will also, I've noted down the LHP biceps SCR as a topic. We'll come to that. For sure, we'll cover, we'll wait for the third speaker and then we'll do a combined discussion on that. Sujit, you have a point here?
Yeah, about of the 17 studies selected, we see that around 70% are from Mihata.
Yes.
Aren't they? So is there a bias or a lack of reproducibility of SCR? One study is with the biceps SCR, as Dr. Radhakarpati asked, but all are with the dermal or the facial autograph with probably with reinforcement of the mesh now, which he's using now in the last 4 years.
See, this is just the nature of the beast. Mihata has tons of articles on the subject, and he has the widest. In fact, to just give you a heads up, Mihata has also published on the Teflon graft article with reasonable short-term results, but he doesn't use the Teflon allograft also. And before we go to Deepthi Nandan Adla, I'll just like to give you a spoiler alert that those of you who may not be aware that Radhakant Pandey and his group from Leicester, including Amit Modi and others, have a volume of research on open patch reconstructions or similar to SCRs with the graph jacket. So there's a volume of experience coming from them. And so their opinion and their experience is very valuable to us. So, Deepthi?
Hi, Ashish. Just a few points actually, because there was a mention about re-tears and subacromial decompressions. There was no mention about the exact rate in these patients and whether they have just done it as a precaution or as a preventive measure, or was an objective observation which they have seen that the re-tears were lesser in subacromial decompressions.
Dinesh, you want to cover that?
Yes, sir. Because all these cuff tears, because of this repetitive microtrauma, particularly the anterolateral acromial spurs, that was the theory proposed ending up in degenerative cuff tears. According to him, acromioplasty, as you mentioned, it increases the working space, decreases the abrasion rate. But when I went through the article, there are no exact measures how much.
The re-tear rates,
Yes,
yeah.
yes.
And they didn't
Also,
mention about what they have done to the biceps in of these studies, right?
Sir,
so Mihata as a practice leaves the biceps intact. Unless it is damaged, then he would do a tenotomy oblique tenodesis depending on the age group. But as a practice, his nature is to maintain the biceps in the original position. He will not change that. So it is not a biceps SCR in his series. As far as I'm aware, I don't think he has done a comparison of with acromioplasty, without acromioplasty. I I understand that he would do an acromioplasty on all his SCR. So I don't think we have a comparison of without acromioplasty group.
And one last point in the technical part is that did they always include the cuff? They repaired the cuff onto the SCR?
No, Mihata just disregards the cuff.
Okay.
The other thing I might like to share with you is Mihata's threshold for SCR is very low. So even if it's a 30 mm tear, Deepthi and myself might go in and do a primary repair, but Mihata would actually go ahead and do an SCR on those. If you look at his first series, almost 7 or 8 patients were type 3 tears, which may have been repairable in our hands. I don't think you can fault him because his results with SCR are brilliant and unmatched. His re-tear rates are very low. So whether you do a primary or a SCR, if it's going to be enduring and giving the kind of results, then probably justified.
Because the definition of that irreparable is a bit variable in the sense, how did he come to that? Yes, that is the main negative point of all these, most of the studies, where the irreparability is not defined correctly.
No,
In the
thing
sense, Nandan, there are many surgeons I know in Europe who would do a pre-op decision. Whereas you and me will keep both options open and keep both options going. If it's not repairable, then you switch to SCR. They're not designed that way. And so I've spoken to Philip Moroder and others and Carl Weiser as well, that they take a decision. Sometimes I would do a repair SOS reverse. They would never ever do that. If it's decided and if it's 75. See, the patient's willingness is not an issue for them. The insurance is not an issue for them. These are additional factors which are very important, and we have to take a responsibility for that. And my patients would prefer a anatomical repair if possible. But that is not the sacred truth. You must also understand that whenever we are doing a large cuff repair, the re-tear rates are very high. They are much higher than an SCR. So when I discuss this with Mihata says if my SCR re-tear rate is low and my function restoration is high, why should I bother doing a repair of a diseased tendon which is likely to re-tear? That's the difference in his thinking.
Sir, can I ask?
Yes, Karthik.
Study, according to the study, there was repair of the residual cuff to the graft posteriorly. So he does do something to the remnant cuff. He repairs the he attaches the remnant cuff to the graft he puts in, right? He doesn't just leave it there.
As far as I understand, he does an SCR. The graft is repaired to the intact infraspinatus to connect it. In his initial days, he used to repair it to the subscap and the infraspinatus, but he noticed stiffness and pain anteriorly. So he recommends don't repair it to the anterior tissue, leave it open, leave the rotator interval as it is, but definitely integrate the graft to the infraspinatus to create that force couple and allow it to be a seamless watertight repair. He's not repairing it to the residual tendon.
Sir, can I contribute, sir? Sir, Ayyappan Nair.
Yes,
sir. Sir, yeah, what you said is right, sir, because when you repair it to the remnant subscap as well as infraspinatus, it creates a lot of tightness. So those patients, especially forward elevation, is very much limited. So that's why, according to the biomechanical study, he modified it and he does only posterior. That is infraspinatus to the SCR is always done. And so regarding the biceps, initially he used to release all the biceps. He used to cut off all the biceps. Bicep tenotomy was a must for him. But later he, as you said, used to leave the biceps. Just to leave the biceps alone.
Yeah.
Sir, this what if there is no infra and teres minor? Would you still go ahead and do a SCR?
Sir,
no, but that is a contraindication.
Yes. It's a contraindication. You need the anterior and the posterior post couples. Only then you're supposed to do it. It means, sir, if the infraspinatus and teres is not there, definitely the extensor lag is positive. You don't have extensor power. That's a contraindication to do the SCR.
Good. Let's move to Prashanth, and we'll do a proper discussion and keep your questions, write them down on the side, and then we'll have no limitations to what questions we can. But we'll give Prashanth the opportunity to complete his talk, and then we'll get back to everybody again. Go on, Prashanth.
Yes, sir. Am I audible, sir? Shall I start?
Yes, you are audible.
Good evening, sir. I'm Dr. Prashanth, fellow at KS Orthocare. I thank all the office bearers of SESI, Dr. Reddy sir, and Dr. Karthik sir, and all the senior staff and my colleagues. Today's Journal Club article is minimum 2-year clinical outcomes after superior capsular reconstruction compared with reverse shoulder, total shoulder arthroplasty for the treatment of irreparable posterior superior cuff tears in patients younger than 70 years. And then the study was mainly written by Peter J. Millett, who was the main surgeon of the cases over which he operated. Study design was a retrospective cohort comparison study, and it had level 3 evidence. Coming to the introduction, chronic massive posterior superior rotatory cuff tears are challenging to repair because of tendon retraction and inelasticity, as well as muscle atrophy and fatty infiltration they develop with time. Various surgical procedures have been used for the treatment of irreparable posterior superior rotatory cuff tears, like arthroscopy divided with LHB tenodesis or tenotomy, or partial repair, or patch augmentation, or complete repair. Reverse total shoulder arthroplasty is a predictable treatment option for patients with irreparable posterior superior rotatory cuff tears when the deltoid is functioning well. Although RTSA was historically used in the elderly population, the indications for RTSA have expanded to younger population as well. However, high complication rates and durability of the implants still remain a concern. So Mehta et al. Introduced superior capsular reconstruction using facial autograft as an alternative treatment for patients with symptomatic massive irreparable posterior superior rotator cuff tears without glenohumeral arthritis. And he reported excellent clinical and radiographic outcomes with a high return to sports rate and low complication rate in a young and active patient population. Subsequently, to expedite the procedure and to avoid donor site morbidity, the SCR technique was modified to use human acellular dermal allografts. Given concerns over complications and survivorship after RTSA in younger patients, SCR represents a promising new joint preserving treatment alternative for irreparable posterior superior cuff tears without glenohumeral osteoarthritis. Purpose of the study was to compare minimum 2-year clinical outcomes, return to sports, patient satisfaction in patients younger than 70 years without glenohumeral osteoarthritis who received surgery with either RTSA or SCR using dermal allograft for the treatment of irreparable posterior superior cuff tears. They hypothesized that the clinical improvements, return to sports rates, and patient satisfaction would be similar to the RTSA patients. It was a retrospective review of prospectively collected data of patients. The study period was around 2 years in cases of SCRs and around 10 years in RTSA cases, which was from 2006 to 2015. And the sample size was 51. Study subjects, patients with a technically irreparable tear of supraspinatus and or infraspinatus tendons, which was confirmed during either arthroscopic or open surgery. Inclusion criteria was the patients who were less than 70 years, who had no severe glenohumeral arthritis, that is Hamada grade less than 2 and Kelvin-Lawrence grade of less than 3 were included, and patients had to choose the surgery. They were allowed to choose the surgery, either SCR or TSA as treatment of choice. Coming to the patients who were opted for the surgery, they had they mainly presented with complaints of persistent pain, loss of strength or impaired function of the affected arm. On examination, they had a negative belly press sign, and they also had a negative arm low sign, which depicts that they had an intact subscap and teres minor respectively. And on investigations with MRI, they had tendon retraction and muscle atrophy and fatty infiltration of more than grade 3 before the surgery. This is an image showing supracapsular reconstruction. Here is the dermal allograft, and it is posteriorly repaired side to side to the infraspinatus. It's an image showing the reverse total shoulder arthroplasty. Coming to post-op rehabilitation, there was no period of strict immobilization for RTSA group. They were mobilized as soon as on the day of surgery. And for SCR groups, they were immobilized. They were on strict immobilization for first 6 weeks. In RTSA groups, if there was a repair of the subscap, the external rotation was restricted to 30 degrees for the first 3 weeks. Full passive and active assisted range of movements were allowed at 6 weeks in SCR groups, and it was allowed on the day of surgery in RTSA groups. Full active range of movements and strengthening exercises were started at 3 weeks in RTSA and at around 10 to 12 weeks in SCR group. And the patients are allowed for full activity and sports without restriction at around 4 months in both the groups. Coming to clinical and functional outcome assessment, all the clinical and functional outcome assessment were done using various scores like American ASES scores, single assessment numerical evaluation score, and quick dash score, and short form health survey, physical component summary. And patient satisfaction was graded from 1 to 10 scale, with 10 representing the very satisfied. And additional optional questions were asked regarding participation in sports. The statistical analysis were made using various steps. Bivariate statistical techniques were employed to address the primary aim of the group comparisons. Group comparisons were made with respect to baseline covariates using the Mann-Whitney U test or Fisher-Exact test for continuous and dichotomous variables respectively. Mann-Whitney U test was also used to compare minimum 2-year patient reported outcome scores between groups. And Wilcoxon signed rank test was used to compare baseline and post-operative scores. And all these analyses were completed with the statistical computing package R. Coming to results, initially there were 93 patients included in reverse shoulder and 27 in superior capsular reconstruction. At the end, when the inclusion criteria was applied, and at the end of 2-year minimum follow-up, we had only 29 in reverse shoulder and 22 patients in superior capsular reconstruction group. Both groups significantly differed in age and length of follow-up. You can see the p-value is less than 0.001. The age group in both the groups there was a significant difference in age, which was around 56 in superior capsular and a bit older in RTSA groups. And follow-up interval was also around 2 years in SCR group and around 3 years in RTSA group. And based on gender and previous rotatory cuff tears, there was no significant difference among both the groups. All postoperative outcome scores improved significantly in both the groups compared with the preoperative state. With the numbers of available scores, no statistically significant differences between SCR and RTSA outcomes were detected. This is a histogram showing the same. There was no significant difference in both the groups. Again, the scores were no. There was no significant difference in all the scores assessing the patient-reported outcome scores. Coming to return to sport, there was no significant difference in the return to sports responses were noticed in both the groups at baseline and post-operatively. Coming to complications, there was one clinical failure in the SCR group, the patient who developed recurrent loss and loss of function after 1.2 years, and one post-op complication in RTSA group where glenosphere was dissociated from the mental placement and he revised immediately on the post-op day 1. Key finding of the study is there was significant improvement in clinical outcomes and high patient satisfaction at the short-term follow-up of the study. Coming to discussion, in a study by Mew et al., which included 66 patients with mean age of 55 years and 3 years follow-up, there were 15% complication rate noted in the RTSA group, which was done in patients younger than 60 years, and 43% had evidence of scapular matching at the time of latest follow-up. Because the one of the drawbacks of the study was it included the patients with glenohumeral osteoarthritis also. In a study by Ernst Werner, which included 23 patients with mean age of 57 years and 11.5 years of follow-up, RTSA was associated with a substantial complication rate with time, and 39% had more than one complication, and around 9% of the patients reported failed RTSA. In an article by Robert Session, which included 36 patients with mean age of 45 years and 3 years follow-up rate, 25% of the patients showed ASA score as less than 50, and they were considered as failures. The patient in a study of total shoulder arthroplasty. In a study of superior capsular reconstruction by T. Pennington, which included 86 patients and mean age of 60 years who were followed up for 1 year, there was decrease in the superior capsular distance and increase in the acromiomar interval, indicating that there was maintenance of superior capsular stability once the superior capsular reconstruction was done. In a study by Dinard, where there were preliminary results of arthroscopic superior capsular research with dermal allograft, which included 59 patients with 63 years of mean age and 1 year follow-up. He showed that there was successful outcome in approximately 70% cases in his initial experience, but the graft healing was low because the graft selected was less than 3 mm. And again, in a study by Smith, which included 598 patients with a mean 3 year follow-up, they said that SCR is a safe joint preserving option, and short to middle term improvements in patient reported outcomes and range of motion were seen. Advantages of SCR is it is a minimally invasive procedure and anatomy preserving, and it allows relatively easy revision to another SCR or conversion to RTSA in the event of failure of the surgery. Limitations are since it's a short-term follow-up study, mid-term and long-term viability of the SCR using the dermal allograft cannot be predicted, and since the patients are allowed to determine the procedure and they were not randomized, and there may be a selection bias. And so since SCR with DA is a new surgical procedure with strict patient selection, our patient numbers were small, and the length of follow-up was also different between the two groups. Conclusion is SCR with dermal allograft results in a similar post-operative functional outcome in a younger patient population when compared to RTSA for the treatment of irreparable posterior superior cuff tears at short-term follow-up. And we need additional studies for further evaluation to evaluate the SCR outcome for long-term outcomes. Thank you.
So Prashant, thank you.
Thank you, sir.
You have enunciated the paper and what the paper has written and the conclusion of the paper. What I would like from your side is what is the interpretation of this paper, number one, and can you critique this paper as a journal club presentation? All the three papers were given so that you could, as a speaker, you should be able to analyze the paper in terms of its sample size, statistics, design. So any comments from your side about this?
Sir, coming to the paper, the population study was less, sir. 51, around 51 patients were included, and the follow-up interval was also short, sir.
So Prashant, most of the SCR studies are going to be 1 and 2 year. We don't have studies which are more than 3 years.
Yes.
But can you enunciate us what are the lacunae of this study? What are the shortcomings? How would you have designed this study in a better manner? Can you switch off the screen sharing so that we can have everybody on the
Yes.
front panel, Prashant?
Yes.
Just unshare the screen. Yes.
Yeah.
Yes.
Go on.
The number of population study was less, one thing, sir. And the clinical, based on the clinical outcome and return to sports, there was no significant difference between the two groups, sir.
No, that we understood. Any
Yes.
shortcomings? Would Dinesh, Ajikya like to contribute?
The comparison should be the young age is the main entrance, I suppose, sir. Comparison should be
Dinesh, they have given less than 70. For a Western population, less than 70 should be reasonable because their cutoff for reverse is 75. So they are Caucasian population, unlike us. So I wouldn't fault that. Okay, and it's fair enough that under 70 you have to decide between the two. So they've designed that fairly well. Anything else?
I would like to comment that the particularly the selection bias is there, where the patients were given the option to choose SCR versus reverse total shoulder orthoplast. So this is the main bias of this particular paper.
Yes, that's the number one flaw, and I would accept that it is not. Firstly, it's retrospective, so it doesn't carry the same weight as a prospective study. If the same study Prashant had conducted and was randomized, where the slip or the computer would decide what option to be done, that would be a fair study. It's very easy to decide to do the easy patients with reverse and the difficult ones with SCR, and then come out with an ulterior motive. Anything else? Good point, Ajikya. So, number one, we should understand that firstly, this is dermal allograft. So this cannot be extrapolated to Mihata study. But comparing dermal to reverse, if you notice closely, Prashant, when you looked at that chart, there were tremendous omissions on the reverse shoulder side. If I'm not missing, almost 66 patients were omitted, and about 5 to 6 patients were omitted. So whenever you have patients that are omitted, they should bring up a red flag straight away there. So if I don't like my results, and I can always omit, oh, this patient didn't cooperate, or this patient. So 1 or 2 omissions because of lack of follow-up is perfectly understood, because it's impossible unless you're Swedish or Norwegian. It's impossible to get 100% response. But 66 omissions in a group of 93 patients is way too much. It should, I mean, it should not have passed muster with the editorial straight away, number one. Number two, it's a random design. As Ajikya said, patients are selecting the choice of treatment, that this is what I have to offer. It's not a menu card where you can choose what you want to do. There are much more intricacies involved there. Now, putting an SCR against a reverse and expecting good results on both is okay. There's not a big deal there. But largely, if you see, the functional improvements have been in the SCR group because the rotations were restored much better in the SCR group. And that's pretty much par for the course. The reverse is notorious for not restoring rotation. So that difference in external and internal rotation is understood, and that benefit will go to an SCR largely. The return to sports criteria, if you look at, Prashant, the paragraph that was 4 lines devoted to return to sport is pretty vague.
Yes,
We
sir.
don't have a description of was it contact sport, was it overhead sport, or you could be playing carom, you could be playing chess. So we don't know. So maybe the reverse shoulder group was playing table tennis, and the SCR group, because they had a better rotation, were playing lawn tennis. Now that's different, and there is absolutely no explanation of what return to sports, what level return to sports. Although it's a geriatric population, we still would like much more detail. It's very vague there. So I don't think there's any big credibility in telling me what return to sports as such. Yes, Sujit, your hands up. Let's have your
Yes.
contribution.
It is said that in the first group, there are two subsets, one with irreparable supraspinatus alone and another subset with irreparable supra and infra. So can they be compared? Are they being compared like apples and oranges? Because irreparable
Yes.
infraspinatus is a totally different beast.
Correct. Absolutely. I agree
So
with
can
that
they
also.
be compared as one single group?
No, absolutely not.
Mm.
Absolutely not. Yes, Ayyappan.
Sir, that is a very valid point, because if you look at the study, it is on posterior superior cuff tears. So posterior superior basically means your extensor lag is gone, okay, your posterior post couple is not there, and then question of SCR doesn't actually even come there. So if you are doing an
Yes.
SCR, we need an additional augment on the posterior side, like a LT or something like that.
Transform.
But the inherent the title itself is a posterior superior, where it is the contraindicate. So it doesn't make sense that way.
Yes.
Ayyappan, I don't think for Mihata it's a contraindication if infra is gone and even if TRIS is gone.
Absolutely.
Mihata does, yeah.
I agree to that, sir. So I had a discussion, very true, sir. I had a discussion with Dr. Mihata on this. So he used to do infraspinatus, repairable infraspinatus he used to do. But if you look at his result, if you look at all the papers we have seen today, we see that the external power, in spite of being a posterior superior tear, infraspinatus tear, his external preoperative power is still 4/5 or 3/5, which doesn't make sense. I think there is a problem there, because how can you have, when you have a massive tear like this, infraspinatus tear, when in our patient, when we look at the external power, it will be significantly less. So I discussed with him. So when he was saying that he agreed to the point that such patients might not, with external lag or external reduced power, might not do postoperatively well. And he also agrees that okay, maybe an additional force couple should be added there.
See, so what I noticed from Prashanth's paper is this paper is actually building a very rosy picture about doing SCR, and especially the papers quoted in literature about bad results for reverse at 10 years for people who are less than 60 or less than 70 is a little scary. If you have a patient at 65 with a massive irreparable cuff tear but no glenohumeral arthritis, and if you are to give a choice between SCR and reverse, and if you look at the literature, it says that 10% will fail at 5 years or 10 years, then you might as well do an SCR and see if it works. So that's the sort of picture the paper is trying to paint. And I would like to know if Dr. Pandey or Dr. Bhabulkar, do they agree with this point? If a 60-year-old comes with a massive irreparable cuff tear, a posterior superior cuff tear, probably with a repairable subscap, would you think about reverse, or would you offer him something other than reverse? Do you think reverse fails so often and so badly in these patients?
So, Karthik, there are at least 3 articles published in literature that say that the SANE scores and patient satisfaction scores are poorer in reverse shoulder replacement done in young patients. Quite clearly, their expectations, their anticipation of function restoration much higher. Their use, the force that they are using, and so subsequent loosening and failure rates are also. Dislocation rates are much higher in the younger patients than older patients. So that remains a fact, and the Western population is. But slowly, the Western population is extending that lower level. If you looked at that paper from Prashant, the reverse shoulder group was slightly elder than the SCR group. But if you looked at the range, it is scary. It was 46 to 64. So the youngest patient in Peter Miller's group was 46 years old. So that's another. I don't have an answer to that, but that's a fact on published literature that the younger reverses don't do as well as the elderly patient.
Dr. Pandey, do you agree?
Panditji.
Sorry, can you hear me?
Yes, yes.
Yeah.
Yes.
So I fully agree with Ashish there. And an answer to your question, if somebody is 60-ish and has got a cuff tear with no arthritis, and if I can repair the cuff even partially, if I am technically able, I will do an SCR. If not, I will use a biceps tendon SCR, but I will avoid a reverse shoulder if there was no arthritis. In a young patient, I'll try and do something to the cuff. Even a partial repair works. So yes, people are going younger with reverse shoulders, and that is a time bomb waiting to explode in the future.
Yes.
And it is basically pushed more by the Americans, whereas in England we still are fairly conservative, and we do reverses for generally cuff arthropathy rather than just a cuff tear. But if someone is in their 75 and got a massive cuff tear, very painful with no arthritis, I would consider a reverse. What another point I wanted to bring was there is evidence emerging that if you do a reverse shoulder after somebody has had an SCR, so if an SCR fails, the outcome of the reverse shoulder is slightly inferior to the reverses which are done on a, say, virgin shoulders. So that is another evidence. I mean, I think there is a paper coming out soon.
There is one paper.
No,
There
there
is
is
one
one
paper.
paper already.
Yeah, and it's just, if I'm not
Yeah.
wrong, I think suggests that the outcome of the reverse after an SCR is slightly inferior. Is that correct?
True.
Yes, Radha, I'm not too miffed about that because number one, it becomes a revision reverse. So any revision surgery is going to be. Now, for sure, please don't do open SCRs because that violates the deltoid and it will big time compromise the outcome of the later surgery. Number one. Number two, the same thing applies to TKR after HTO, that the results are always going to be inferior. But I'm not too concerned about that. Suppose I would do an SCR for a young patient who's 55 and has ran for 5 to 7 years. I think it's still par for the course. It's still a good, you got your bang for the buck, and then you've done a reverse shoulder and it's imperfect and still works. It still works. So I wouldn't fault that. It has to last, number one. I'm going to bring up some real controversial topics. So I think we are already a little late. So if I can quickly bring up some the controversial part. Number one, the literature is littered with SCRs left and right, but the American SCR is either an allograft or a synthetic graft. And what Mihata does and the synthetic graft is chalk and cheese, is not the same. And Mihata's graft is 8 mm thick wad. Mihata started with a graft that was 5 and 6 mm. He takes every effort to make that graft to be at least 8 to 9 mm now thick. And that is substantial, number one. That's a robust graft. John Tokish, Peter Millett, Alan Harihira, all have published on their SCR versions. They're all synthetic. They are the arthro patches, but they're not the same because John Tokish's graft was 2.5 mm. Peter Millett's was 3 or 3.5 mm, 3 mm, and then Alan Harihira's this thing was 3.5 mm. So there's a big difference. The moment you increase the size of the synthetic graft, its robustness is increasing multiple folds, not only. So it's not the same surgery, number one. Number two, the failure rate of a synthetic SCR is far, far higher. Mihata's published last, I don't know the 2024 article, but the article before that, 2022, was 11%. There's a fantastic article. It's not, it's a review article by Joydeep Sinha. Those who are interested, go and have a look at it. They publish the various failure rates of different materials. So if you're using scaffold, something like a regenerative or a patch or an augment, it's almost 25% failure rate. Whereas the xenograft is 44%. And then allografts are 23%, synthetic grafts are 15%. So this is again collated research amongst all the articles. So it's not the same, the failure rates of India. So you need to know what graft you're using. So don't get overawed and don't start comparing the American SCRs with this. I think they should be labeled as something else. The SCR should be credibly labeled as Nihata's SCR or SCRM, not SCR synthetic as such. Now, to just give you a fair idea, the Peter Millet failure rate of synthetic SCR was 45%. You must read the Label paper, which says that even after the graft failed, patients still did well. Their failure rate was 62%, only 38% grafts were intact. Again, it's a human acellular dermal graft. Okay, so if the procedure is working at 62% failure rate, there has to be some logic and some method in this madness. So now let's understand the failure rate of an SCR. Now, if the SCR was to fail at 6 months, it has given ample time for the biomechanics of the body to be restored, the force couples to come into play, and the head to come back into the center of joint, correct the proximal migration. And then it is the force couples that are running through and carrying this heavy weight. And it doesn't matter when the SCR fails. It's like the balloon. If it lasts for 3 months, 6 months, allows the body biomechanics to restore, it's going to work. No isolated graft which is non-vascular, non-active can remain forever. With cyclic loading, it is eventually going to fail. Label's paper is the longest 2-year follow-up, so it's a pretty sensible paper. All the others are 1-year follow-up, so probably reflects the reality of the picture on Label's picture. Now, if this failure were to happen within 5 to 6 weeks of surgery, the shoulder has not had enough time to restore force couples. And those are the patients who have a weak cuff, weak strength. They go and back into proximal migration and they will have a poor result. So none of the papers mention their failure rates in terms of the timeline. We need to know when is that timeline. Okay, so that brings us to the question, what labels a good, well-done SCR? So I just collated a few points that I thought I would worthy to share with all of you. Number one, if you have a pre-op proximal migration and your first day post-op X-ray shows correction of the proximal migration, that means your 8 mm thick wad has worked well. You have centered the head. The body has been facilitated. You're bringing the center of rotation back to where it was. You reduce the stress on the force couples. The force couples will fall in place and then they will get restoration of function. So restore of function means pain-free, good movement, including rotations and strength. Nihata's paper actually says that you can restore cuff strength if the graft is intact. If the graft is not intact, the cuff strength goes out through the window. Number two, the acromial-humeral distance correction is also another important metric that you want to measure in your SCR patients post-operatively and monitor it every few months to the extent that to ensure that the graft has survived this. The graft integrity, of course, if the graft is integral, the AHI is more than 7 mm or around thereabouts, and the proximal migration corrected, that's, I would say, a successful SCR, even if it lasts for 6 months or 1 year. And when it comes to a force couple, if you have a subscap that is torn, then I wouldn't be so gung-ho or a cowboy surgeon to go and do an SCR on a patient who has a subscap that's irreparable. So that was Ajikya's paper. The group 3 will have a very poor result just because the pain reduced. Pain could reduce from a biceps tenotomy or a debridement or, just a steroid injection. But function restoration is not to be expected. So let's not consider the group 3 from Ajikya's paper as a remote indication for the select few patients. So, of course, the results in those grafts that were not torn are far superior in terms of the strength restoration also. But if the graft tears at a reasonable length of time, I don't know whether it's 3 months or 6 months, if the rehab has kicked in well, then that SCR will do well irrespective of the graft size. So do make a distinction between synthetic and IT band that I have mentioned. John Tokish has acknowledged, he's the biggest proponent of the Arthoflex dermal matrix graft, synthetic graft, that the synthetic graft is incapable of restoring or correcting the proximal migration. So there either you need a very strong double-layered thick Teflon graft, which might be able to achieve that. But so far, the biological autograft seems to do far better. The infection rates after allografts are significantly higher than what Nihata's group is. Somebody should have noticed, I don't think people noticed it, but in Ajikya's paper where they compared group 1, group 2, group 3, the infection rates in the third group where the subscap was irreparable was incredibly high. So I can't explain that, because same surgeon, same technique, same quality of graft. Why should the infection be 47% in group 3 and just one patient and two patients in group 1 and group 2? I can't explain that. But it is a pertinent problem, and we don't want. If it gets infected, it has burned all bridges. So we cannot offer a reverse shoulder replacement to that patient. That is also a very important metric. So that's why pick and choose your patients correctly. Last point I would like to make, 2 points I would like to make. As Pandeyji suggested, the biceps SCR is also a very robust graph. On the biomechanical studies that Dinesh presented, the LHB SCR was probably more stronger than the IT band SCR in one of the biomechanical studies which were done in the lab. So that's probably because the enthesis on the glenoid side is intact, so it is native. Nothing can beat the enthesis as compared to an anchor repair on that. Personally, in my opinion, completely anecdotal, I use the LHB SCR as an augment to a repairable or a partial cuff repair. Again, for the same reason, to prevent proximal migration and protect my partial or a tenuous cuff repair. But I will always reroute the biceps into the center of joint so that it can be a nice, good beam to prevent that proximal migration. If you leave it anteriorly, I don't think it's capable of doing the proximal migration. But my SCRs are for irreparable cuff tears, not for those tenuous repairable cuff tears. So that is the 2 bits that I would like to share with you. Any other comments from panel? Ayyappan?
Sir, so we are doing, because SCR numbers have been increasing a lot. We've been doing, all of us have been doing a lot of SCRs. So,
yes,
sir, what my sincere suggestion would be like to everybody would be like, we should always look at the external rotation power. Because I looked at my cases, so I had repairable infraspinatus in all my cases. It was always it was repairable. So I was able to repair the subscap and the infraspinatus nicely. But still, when I looked at my results, I found that those patients who had a initial external rotation lag positive or the external rotation power is less, they tend to do very badly. Means they don't recover their forward elevation. So I think that one point, because we are doing on a big scale, but still, I will always add an additional. I'll go for a LT in those kind of cases when there is a process. External rotation lag is the SCR. I might not do at all. I might just do a lower trip. Yes.
Yeah, it's a good point that you mentioned. At the shoulder conclave in Jan, we had Mihata himself do a live superior capsule reconstruction, and we had Basam do a live lower trapezius transfer. And it was inevitable that one of the delegates came up with an audacious question that, boss, when would you do an SCR with a lower trapezius? Yes. And then I had to intervene, and I said that, see, let's not go into the ephemeral, and let's stick to what is simple, and these are 2 different techniques. Having said that, I had no idea. Within a month, I had a patient from Bangladesh who had a road traffic accident 6 months back, age 54, and he had a GT that underwent complete osteolysis, complete drop arm. And when he came in, he had an external rotation lag along with this. And I realized that if the external rotation is weak, the SCR is not going to function. So he's my only patient where I've done a SCR with a lower trapezius transfer. I have corrected his lag. He has developed his external rotation to +20 now. But still early days yet. I operated him in March, so it's only 3 months. It's going to take much longer to work on him. Yes. But those are rare cases. If you don't have a force couple, then don't do this, because it's not a one-trick pony where the SCR is going to work any which way. The SCR is a means of getting your therapist to work ideally to restore the force couples. Yes. The force couples have to come in place. So the SCR is not a magic wand where you just do an SCR and leave it and forget it.
Yes, sir.
Can I ask?
Sir, I just sir, I started doing this, sir. I started doing the biceps SCR, because in the SCR with the lower trap is difficult. So, but in the biceps SCR plus the lower trap, I started to do with excellent results. Yes. Thanks.
Is another combination that you could. Yeah, sure.
Yeah.
Yes,
my question was when you do a lower trap, like what Basam does, he keeps an anterior posterior bit of the graft as well.
So
Yes.
I understand that works as an SCR by itself by increasing the acromial distance, and then the rest of it goes posteriorly. So isn't that enough? And what was the SCR you used for the Bangladeshi patient? Was it a facial lata graft or was it a biceps
Yes,
along?
yes. I always use a facial lata.
Okay.
So we had a good discussion with Basam that if there are some small select group of patients who have an intact infra, it is wasted, there is fatty infiltration, it is weak. So weak infra, I'm not too worried, but if they have a lag, then it is still justified doing a lower trapezius with an intact infraspinatus.
Mhm.
You understand?
Absolutely.
Now,
Absolutely.
It was
if you
infiltrated.
ask me that will the lower trapezius transfer substitute a supraspinatus? I don't think so. So if you have a proximal migration with external rotation lag, it's not going to work. But if you don't have a proximal migration, and if you have a robust lower trapezius, which means I need a red neck male, then in isolation, that lower trapezius will match and give you a composite subscap external rotation power to be able to overcome that drop arm, for sure. Now, if this was a female which is wasted and short, then the lower trapezius itself may not move the needle enough. At the end of the day, you have to do that decision of how well can you restore the force couples.
Yes.
One last question.
Yes,
How
Vinny.
did you manage
Yeah,
the
sorry.
anchors? Yeah, sorry. the
So
lower trap with
that was the
subscap.
trickiest question because the SCR coming in, that had to be the robust thing. So I got the lower trapezius to come round and inserted them much more laterally beyond.
Okay.
And then I ensured that my SCR was not a long graft which was covering the full footprint. So instead of having a 55, I used a 50 graft medial laterally. Yes, Vinny.
Yes. So from the first paper, actually, out of 160, 147 had infraspinatus and 13 had teres minor tear also, 3 tendon tears. So the takeaway from this is that means if their infraspinatus and teres minor are torn, then they should be repairable for the SCR to be successful. That's correct?
Yes.
So
Yes.
he must have repaired all this, so that's why he's got such good results.
Yes, yes. But there's a spoiler alert here. Whenever I needle Mihata about infra with supra, he is very cagey on, he's not happy with his results. At the same time, when you have a subscap tear and that is repairable, then the results are almost equal to doing an isolated SCR. The infra is a different beast. Now, if you ask me why you see subscap tear, I don't have an answer to that. The roller ringer effect and blah, blah, and subscap is a very big muscle. So even if it wastes and has fatty infiltration, it's still worthy repairing. A lot of the infra tears are associated with suprascapular neuropathy or fatty infiltration. And so we are doing a damn nothing for the nerve and the contribution. And if you see fatty infiltration in the infraspinatus on a T1 side, then be very dicey. I'm not going to offer an ACR for that patient. Then if that patient is 60, 65, I'd rather go in for a reverse on those patients.
Okay. Thank you.
So, Ashish sir, I think it was a wonderful discussion, beautifully summed up, very controversial topic. It's still not over. I've got. Can I just sum up the discussion today? What I understood from what you said.
Go on.
So we got a patient with no superior migration and ER lag. Then you would choose a lower trapezius transfer.
Yes.
So the patient has no superior migration and only ER lag, which means that the infra is not working. Then probably a lower trapezius transfer is a better option. If the patient has superior migration but no ER lag, then SCR will be a better option. So here we earlier used to think that SCR and LT or latissimus dorsi, they have similar indications, but it's not like that. So
no.
ER weakness and there should not be minimal superior migration for the lower trap to work. But for the SCR, superior migration is okay, but ER lag should not be there. So what if both superior migration and ER lag is there? Then probably reverse is the way to go. Is that what you think?
Yeah, in a 60 plus patient, I don't hesitate giving a reverse. It is more predictable, reliable, and consistent in giving results. If that patient is 50, then there's a dilemma there.
Okay, so we are still.
It's a rare association. It's not so common.
We do see sometimes patients with massive cuff tear where even the subscap is gone, patient has ER lag, and there is some superior migration, and the patient is probably 55 or 60. It's a very rare thing. I totally agree. It's a rare scenario, but that's a scenario where we are not very clear in young patients, but in an elderly patient, we can safely offer a reverse. So I think this is yeah. So I'm correct. So that's good. So anything else to add?
No, I just want to make a few pertinent comments. Number one, the whole purpose of these three controversial papers was to stoke the fire. Like Vineet put up on the chat group that these are retrospective studies. Vineet, the intention was to keep flawed because I want the younger moderators to find flaws in the paper. It's very easy for us to read a paper and replicate whatever is given in that. A journal club, and I'm making a plea to Karthik to ensure that the future journal clubs have to be intense debates about the study design, about the flaws in the paper, about the sample size calculation, about the statistics, or if nothing, that these were wrong comparisons, or the results are something else and the conclusion is something else. And the fact that they're retrospective, and then at the end of the day, if I were to be the lead paper writer, how would I do the same paper better? This will instill the research basics and fundamentals into our next generation better way. So the whole idea was that you don't want to give a perfect paper for everybody. So for the speakers, I think they did an excellent job. They highlighted everything, but a lot of it was reiterating what was written in the paper. We don't want to replicate that. We want analyticals. So we must be able to read papers, counteract them, and give a counter view that this paper was better than this paper. So that's why those three papers are handpicked, so that I could see so many glaring omissions in those papers, number one. So lastly, in conclusion, we don't need to be evangelical about the SCR. It is not a fill it, shut it, forget it surgery. If we know the correct indications, there are few and far indications, then a lot of these patients are repairable. Like Karthik said, you have a massive tear. They come to us. Most of them are repairable. And we should be able to repair them, and nothing beats an anatomical repair. But you need to be prepared that when I see a massive tear, which is 40 mm, I can't tell you for sure that patient is repairable. So I don't know the quality of the tendon, and I don't know the pliability of the tendon. So in those patients, I will always say that I'm going to make my earliest effort to repair it. But at the point, I will always keep a SCR option ready mentally, that I'm ready mentally, and also the positioning of the patient, the graft is all prepared in position. That is how the approach should be in the ideal world. Thank you very much. I think I enjoyed this. The discussion was very fruitful. We had a fantastic exchange of ideas, and this is how it should be. Congratulations, Karthik and Deepthi. If you continue this good work, by the end of the year, we'll be much wiser than what we were in last year.
So the whole idea of starting this was getting our people to read a paper critically and analyze it critically.
Yes.
As Reddy pointed out, we are just started in that direction. So hopefully with few more sessions, we'll be there. In fact, in the next journal club, we are hoping that all the senior faculty will present papers, and they will let us exactly know how to critically analyze the paper. So that we, and I thank you very much for joining, sir. Sir, Deepthi, sir, you want
Perfect.
Yeah, thank you very much, Ashish, for moderating. I think that was an excellent way of getting it forward. I think what Karthik just mentioned is getting the senior guys on board and getting the critical part of analysis of these papers very important. And we have been doing in the last few journal clubs, actually, we have looked at the flaws in the papers and whether that message which has come through is the real message, or is it a message which is just catching your eye. I think we should be very careful about what message you take out of paper. And as you rightly pointed out, we need to be more critical about their papers as well. So I think, Karthik, next time onwards, if you have one senior person present again with two different juniors, then we can get everybody in sync. That will be a better idea for us.
Okay.
Thank you very much, Dr. Rajakant Pandey, as well, for joining us and giving us that insight into the grab jacket and the other parts of non-SCR surgery options for irreparable cuffs as well. Thank you very much again, Karthik. I think we'll continue doing this on a
Thank you,
regular
Ashok.
basis.
So until we meet
Thank you.